Welcome back to the deep dive. Today we are doing something a little different.
A little different, yeah.
Usually when we talk about architecture, we're talking about skyscrapers, maybe bridges, the layout of a city. But today we are shrinking that lens way, way down.
All the way down.
We're looking at the architecture of the human body, specifically the neck.
It really is an architectural marvel and, well, a nightmare, depending on who you ask.
Right. I think most of us look in the mirror and just see, well, a neck. It's the thing that holds up the head.
Sure.
But after going through Dr. Sujatha's breakdown on neck dissection, I'm realizing it's more like a high-stakes superhighway packed into a very tight cylinder.
That is the perfect analogy. It is a superhighway. You have the carotid arteries carrying blood to the brain, the jugular veins bringing it back, nerves that control your tongue, your shoulders, your voice.
All just crammed into this narrow space.
Exactly. And the challenge of neck dissection, the surgery we are unpacking today, is how to navigate that space when it's been invaded by cancer.
It sounds incredibly high stakes. The source material describes this not just as a medical procedure, but as a navigational challenge. We aren't just cutting things out. We're trying to clear a minefield without setting anything off.
That's it. The mission of this deep dive is to unpack the logic behind that surgery. We want to understand how surgeons systematically clear out metastatic lymph nodes, the bad biology,
Right.
while preserving those vital highways we just mentioned. And as Dr. Sujatha outlines, it's a discipline that combines history, anatomy, and honestly, a bit of geometry.
Geometry is a surprising word to hear in the operating room, but we will get to that when we talk about incisions.
I will.
But first, let's orient the listener. What exactly are we talking about when we say neck dissection? Because Dr. Sujatha emphasizes a very specific definition involving fibrofatty tissue.
Right. This is the first hurdle to understanding the surgery. You might think, okay, the patient has cancer in a lymph node, just go in and pluck out the node.
Like picking an apple off
Yeah.
a tree. Yeah, that would be the intuitive assumption.
But it's wrong. In cancer surgery, if you just pluck the node, you are likely leaving behind microscopic disease in the tissue surrounding it.
Okay.
Think of the lymph nodes as being embedded in a layer of fat and connective tissue. That's the fibrofatty tissue. It's the soil the nodes grow in.
So you can't just take the weed, you have to take the soil.
Exactly. The definition of a neck dissection is the surgical excision of that entire package of fibrofatty tissue. You remove the whole block to ensure you catch not just the obvious cancer, but the microscopic seeds that might be hiding in the neighborhood.
It's a clean sweep operation.
That's the one.
That makes sense. It's about margins and safety. But surgeons didn't just wake up one morning knowing how to do this safely. The history here is surprisingly deep.
It is. The source material actually takes us back to the 17th century.
1622 to be precise. Gasparo Aselli. Now I'm guessing he wasn't doing radical neck surgeries in 1622?
No, definitely not. Anesthesia was still a few centuries away.
Right.
But Aselli is crucial because he described lacteal vessels. He was the first to really identify that there was a system of vessels separate from the blood. He found the pipes, essentially.
You can't fix the plumbing if you don't know the pipes exist.
You got it.
So Aselli draws the map. When do we actually start trying to fix the plumbing?
It takes a while. We jump to 1847 with a surgeon named Warren who introduces some operative techniques. But the real turning point, the moment this stops being an experiment and starts being a standard procedure, is 1906.
George Crystal Sr.
George Crystal Sr., a
Well-
giant in the field. He described the first standardized technique for removing these nodes. He basically said, we need a repeatable, systematic way to do this.
But even Crystal isn't considered the father of modern head and neck surgery, right?
Yeah.
That title goes to someone else in the notes.
That title belongs to Hayes Martin. If Crystal built the frame, Hayes Martin built the house. In the mid-20th century, Martin described what we call the radical neck dissection.
Ah.
And for decades, this was the gold standard. It was the yardstick against which every other neck surgery was measured.
And radical here isn't slang for cool, it means aggressive.
Very aggressive. Hayes Martin's philosophy was clear. Get the cancer out at all costs.
So let's unpack that because this leads us into the classification system, the menu of surgery options, if you will.
Mhm.
The radical neck dissection is the baseline. What exactly are they taking out?
Okay, so in a radical neck dissection, you're removing all the lymph node groups on one side of the neck, levels I through V.
All of them.
But, and this is the radical part, you are also sacrificing three major non-lymphatic structures.
Okay, let's listen. What's first?
First, the sternocleidomastoid muscle.
That's a mouthful.
It's the SCM. It's that big strap-like muscle you can feel popping out when you turn your head to the side. It gives the neck its shape and protects the major vessels.
And in a radical dissection, that comes out.
It comes out.
So the patient's neck looks different.
Yes, it looks sunken, hollowed out on that side. It's a significant cosmetic deformity.
Okay, what's the second thing to go?
The internal jugular vein. This is the main drain pipe for blood coming from the brain.
Right.
Now, you can survive with just one. You have two, one on each side. But removing it changes the hemodynamics of the head. It can lead to swelling and pressure issues.
And the third?
The spinal accessory nerve.
That sounds important.
It is vitally important for quality of life. This nerve controls the trapezius muscle. If you cut this nerve, the patient loses the ability to lift their arm above their shoulder.
Oh, wow.
They get what we call a frozen shoulder. It's painful, it causes the shoulder to droop, and it limits their daily function essentially forever.
So Hayes Martin's deal was, I will save your life, but you're going to lose your neck shape, one of your main veins, and the use of your shoulder.
That was the trade-off. And for a long time, it was accepted because the alternative was dying of cancer.
But as medicine advanced, surgeons started asking, do we really need to be this destructive?
Exactly. Which brings us to the second item on the menu, the modified radical neck dissection. This is the evolution toward preservation. In a modified radical, you still remove all the lymph nodes. So the cancer part of the operation is just as thorough,
Still getting the job done.
but you try to save one or more of those three non-lymphatic structures.
So maybe you peel the tissue off the nerve, but leave the nerve intact.
Precisely. If the cancer hasn't invaded the nerve, why cut it? By saving the spinal accessory nerve, you save the patient's shoulder function. By saving the SCM muscle, you save the cosmetic appearance of the neck.
It's about maximizing quality of life without compromising survival.
That's the whole game.
That seems like a massive leap forward for the patient. But the list goes on. We also have selective neck dissection.
This is the era of precision. The sniper approach versus the carpet bombing.
How so?
Well, we learned over time that cancers are predictable. A cancer on the tongue tends to spread to specific lymph nodes. A cancer in the throat spreads to different ones.
They have patterns.
They do. So if the cancer is caught early, do we really need to clean out the entire neck?
Probably not.
Right. So in a selective dissection, we preserve specific lymph node groups. We only take the ones at highest risk. This means a smaller incision, less trauma, and a faster recovery.
But surely there's a flip side. What happens when the cancer is worse than expected? The notes mention an extended radical neck dissection.
That is the all hands on deck scenario. That's when the cancer has broken out of the usual boundaries. It might be invading the skin, the deeper muscles of the neck, or other nerves,
So extended means you're taking the standard radical package.
plus whatever else is involved. It's usually a salvage surgery.
So we have a hierarchy. Radical, which is take everything. Modified, save the structures. Selective, take only high-risk nodes. And extended, take even more.
That's the classification in a nutshell.
Now this connects to another distinction Dr. Sujatha makes that I found really interesting. The difference between elective and therapeutic surgery.
Right.
Elective usually implies optional, like getting a nose job.
Right, but in cancer surgery, elective doesn't mean if you feel like it means prophylactic.
Can you explain that?
Sure. Therapeutic dissection is straightforward. You feel a lump or you see a swollen node on a CT scan. The disease is clinically present. You operate to treat it.
Okay, makes sense.
Elective is when the neck looks clear. We call it clinically negative. You can't feel anything, the scan looks okay. But
But you know the statistics.
you know the statistics. We know that for certain tumors, there's a 20 or 30% chance that microscopic cancer cells have already traveled to the neck, but they are just too small to see it.
Invisible enemies.
Exactly. So an elective neck dissection is clearing the brush before the fire starts. You remove the nodes because the risk of leaving them is too high, even if they look normal today.
That is a heavy decision, cutting into a healthy-looking neck on the probability that something might be there.
It is, and that leads us right into the decision-making process, the go-no-go criteria. Dr. Sujatha breaks this down into indications and contraindications.
The indications seem to align with what we just said. If there are positive nodes, you go. If there's a big tumor T3 or T4, you go.
Correct. The no-go, or contraindications, are where the ethical and practical limits come in.
And there are absolute contraindications, meaning under no circumstances do you operate.
Right. The biggest one is distant metastasis. If the cancer has already spread to the lungs, the liver, or the bones,
The horse is out of the barn.
it is. A neck dissection won't help. This is a local control surgery. It doesn't cure systemic disease. So putting a patient through the trauma of neck surgery when they have stage 4 spread is ethically wrong. It offers pain without gain.
And inoperable neck disease. What does that mean?
That's the frozen neck. When the tumor is so massive and invasive that it's fixed to the spine or the base of the skull, you physically cannot get around it to remove it safely.
But then we have relative contraindications, things like poor general health.
Yeah, if a patient has severe heart failure, the surgery might kill them before the cancer does. You have to weigh the risks.
But here is where the story takes a dramatic turn. There is one structure in the neck that used to be an absolute contraindication, a do not touch zone, and now it's relative.
You're talking about the carotid artery.
The main fuel line to the brain.
Exactly. For decades, the rule was simple. If the tumor is wrapped around the carotid artery, the patient is inoperable.
Game over.
Game over. You cannot remove the tumor without the artery, and you cannot remove the artery without causing a massive stroke or death. So you closed up and sent them to palliative care.
But Dr. Sujatha notes a shift.
Yes. And this is a testament to the incredible advancements in what we call reconstructive surgery. Today, in highly specialized centers, carotid involvement is often considered a relative contraindication,
Meaning they can fix it.
meaning they can rebuild it. Surgeons can now resect a segment of the carotid artery along with the tumor, and then replace that segment with a vein graft from the leg or a synthetic tube.
That is wild. It's like replacing a section of pipe while the water is still running.
They use temporary shunts to keep blood flowing to the brain while they stitch the new vessel in. It is incredibly high risk, let's be clear about that, but it has moved the line of the impossible.
It gives a chance for a cure to patients who previously had none.
A real chance.
It really changes the landscape of what is considered inoperable. Okay, so we've decided to operate. We know what we're taking out. Now we get to the part that felt most like a geometry class, the incision.
The art of the opening.
It turns out, you can't just cut a straight line to be done with it. Dr. Sujatha outlines these competing goals: access, vascularity, and cosmetics.
It's a three-way tug of war. First, access. The surgeon needs to see. If you can't see the nerves and vessels, you're going to cut them by accident, so you want a big opening.
Right, makes sense.
Second, vascularity. This is critical. When you cut a flap of skin and lift it up to work underneath, you are cutting off the blood supply from the sides. That flap has to survive on blood flowing from its base all the way to the tip.
So if the geometry is wrong, if the flap is too long or narrow,
The tip won't get blood.
and then the tissue dies.
It creates flap necrosis, the skin turns black and dies, and if that happens, you have a gaping wound exposing the very arteries you just tried to save. It's a disaster.
Yeah, and the third factor is cosmetics.
You don't want to leave a scar that runs right down the middle of the neck if you can avoid it.
So let's tour the incisions Dr. Sujatha describes. We start with the old school, the Hayes-Martin incision.
The double Y. Picture a Y lying on its side, one cut below the jaw, one above the collarbone, and a vertical line connecting them.
It opens like a barn door.
It gives amazing access, you can see everything, but it fails the geometry test.
How so?
The trifurcation. The point where the three lines of the Y meet. You have three sharp corners of skin meeting in one spot. The blood supply to those corners is terrible.
And that's a problem.
Dr. Sujatha specifically notes that necrosis at this junction is very common,
And where does that junction sit?
usually right over the carotid artery.
That sounds dangerous.
It is. If the skin dies and the wound breaks down right over the artery, you risk a carotid blowout. The artery ruptures. It is a catastrophic, life-threatening event.
And a scar isn't great either.
Not at all. A vertical scar down the neck tends to contract and thicken, creating a tight band that restricts movement.
So, high risk, bad scar. Let's try the next one. The McPhee incision.
The latter. This was an attempt to fix the scar problem. Two horizontal cuts, one high, one low. No vertical line connecting them.
So you leave a bridge of skin in the middle.
Correct. A bipedicled flap.
It sounds great for cosmetics because the scars hide in the natural neck creases.
Cosmetically, it's the winner. But for the surgeon, it's a nightmare.
Why?
Imagine trying to clean out a complex room through the mail slot. You have to work under that bridge of skin. You're retracting it up and down, struggling to see.
Dr. Sujatha mentions this is especially hard in patients with short necks.
Or obese patients. If the neck is thick, that bridge is heavy and tight. If you start bleeding under that bridge, good luck finding the source quickly.
So while McPhee's pretty, it sacrifices access and safety in difficult cases.
Big time.
Then there are the triradiate incisions, the Cryal and the Schobinger.
These are variations of the Y shape. The Schobinger tries to fix the Hayes-Martin by curving the vertical line into a lazy S shape.
Okay, what does that do?
It moves the scar so it doesn't sit directly on top of the carotid. It's better, but you still have that three-point junction where skin can die.
So we have the risky Y, the difficult ladder, Do we have a winner? What is the standard today?
The winner is the apron flap, also known as the Gluck Sorensen incision.
Describe the architecture of the apron.
It's a long U-shaped cut. It starts behind one ear on the mastoid bone, sweeps down low across the bottom of the neck, almost to the clavicle, and comes up behind the other ear.
It crosses the midline.
Yes, mastoid to mastoid. Think of it like lifting the hood of a car. You lift this entire apron of skin up.
Why does this design win?
First, blood supply. The base of the flap is incredibly wide, so the blood flow is robust. The risk of necrosis is very low.
And access.
Access is fantastic. When you lift the hood, the entire neck is exposed. You can see everything perfectly.
And safety.
The incision line is low. It doesn't cross the carotid artery in a dangerous way. If the wound has issues, the vital structures are still covered by the main flap.
And surprisingly, Dr. Sujatha notes the cosmetics are actually pretty good.
They are. Because the scar is so low, it's often hidden by a shirt collar. It avoids that ugly vertical band in the middle of the neck. It really is the Goldilocks solution. Good exposure, safe blood supply, acceptable scar.
It's fascinating to see how the field navigated this. It wasn't just about understanding the cancer, it was about understanding the engineering of human skin.
That's a great way to put it. Surgery is an iterative process. We went from the 1600s discovering the vessels to the 1900s with the radical approach of taking everything out to ensure survival, to the modern era where we balance survival with function and appearance.
It seems like the definition of success has changed.
It has. In Hayes Martin's day, success was the patient is alive. Today's success is the patient is alive, their shoulder works, and they can look in the mirror without being reminded of their cancer every single second.
It's a move from brutality to empathy, facilitated by better anatomy knowledge.
Absolutely. We are constantly trying to tighten the margin, saving millimeters of tissue to save miles of quality of life.
And I want to circle back to that carotid artery point one last time before we go. The idea that something was absolute and is now relative.
It's the most provocative takeaway for me. In medicine, we love to draw hard lines. This is impossible. This is inoperable.
But the history of neck dissection proves those lines are written in pencil.
Exactly.
Because technology catches up.
The anatomy hasn't changed in 400 years. Aselli saw the same neck we see today. But our tools, our grafts, our anesthesia, our understanding have transformed. Makes you wonder, what currently impossible surgery will be routine in 20 years?
Maybe one day we won't be cutting it all.
That's the dream. But until then, we have the apron flap.
And a whole lot of surgical logic. Thank you for guiding us through this. It's a reminder that beneath our skin is a world of incredible complexity that surgeons have to navigate with a map that took centuries to draw.
My pleasure. It's a fascinating landscape.
And thank you to our listener for joining us on this deep dive. Next time you turn your head to check your blind spot in the car, spare a thought for your sternocleidomastoid. It's doing a lot of work. Until next time, stay curious.